So coming to the last talk, Dr. Madhavi Pillai will be talking on gauging the MIGS and its role with swept source anterior segment OCT. Dr. Madhavi.
Thank you, Scientific Committee AIOS, and thank you, Aparna ma'am, and my mentor, Dr. Devendra Maheshwari sir, for giving me this opportunity. Good afternoon, one and all. Today, I'll be speaking on gauging mix with swept source ASOCT. Now that we have seen quite a lot of minimally invasive glaucoma surgery procedures, we would like to know which of these procedures are really effective, and what are the structural changes that takes place after these MIGS, and what are going to be the long-term effects, and is there a way to assess it actually? So ASOCT and ASOCT angiography helps us to visualize the aqueous outflow pathways, angle anatomy, and we can also, in cases of device-based MIGS, we can see the implant placement and also look at the structural impact after the minimally invasive glaucoma surgery. So I have no financial disclosures, but most of the presentation I'll be showing images from Cassia 2, that is from Tomy, Japan. So these swept source ASOCT gives high resolution images, and they have a faster scan speed and deeper penetration with a wide field view, and you can see a beautiful gonioscopic and three-dimensional view with this swept source ASOCT. So this helps in preoperative patient selection and planning. Intraoperative, Madam has already shown beautiful intraoperative OCT. I'll be concentrating on the postoperative effects of this swept source ASOCT. So as I already said, in device-based MIGS, we can look for the placement of the devices like eye stent and hydrous stent, whether the devices are placed in the proper anatomical position. Here you can see the hydrous stent. So coming to the excisional based goniotomies, so we can look at the clefts in the excisional goniotomies, like in this case, the KDB goniotomy. So you can see a beautiful cleft in the clean cut and beautiful cleft in cases of KDB goniotomy. So these are the various sections actually moving along, you can see with the help of the swept source ASOCT. So you can see how beautifully and clean cut the cleft is. So next, coming to the bend ab interno needle goniectomy. So here, if you compare with the KDB goniotomy, you can see the cleft is not as well defined as that with the Cahook dual blade goniotomy. So this proves that the KDB goniotomy, which is specially designed for that purpose, while the bend ab interno needle goniectomy is not designed for the purpose, so the cleft may not be as well defined as with the KDB goniotomy. But we don't know how the impact on IOP is going to be. So this is how the structure at the angle anatomy looks like. So with Tanito microhook trabeculotomy, so now we talked about the excisional procedure. While Tanito microhook trabeculotomy is actually a cleavage procedure which cleaves the trabecula meshwork and the inner wall of the Schlemm's canal. So let's have a look how the ASOCT looks like in Tanito microhook trabeculotomy. So here you can see, compared to the clefts of the KDB goniotomy and the bang, here you can see a thin cleft, thin and narrow cleft. So this is actually an incisional procedure rather than an excisional procedure. So once again, while moving through the sessions in the nasal angle, here you can see the cleft of the Tanito microhook trabeculotomy. So this again is the how it looks so beautiful in the three-dimensional view of the Tanito microhook trabeculotomy. You can see the cleft here in the 3D view. So when it comes to GAT, we know that it is a 360-degree trabeculotomy. So post GAT, you can see both the nasal as well as the temporal angles. There is a beautiful cleft. Once again, this is how the 360-degree view looks like in a three-dimensional aspect of the swept source ASOCT. So moving through the sections, you can have how the cleft looks like in each section, in each angle, nasal as well as temporal. So this is how the objectively we are looking at qualitative analysis of the ASOCT. So this is one particular case in which GAT was done in a case of post-RD. So while moving through the section, you can see the tube here. And you can, as well as the same section, you can see the cleft also of the GAT cleft also see. So this is another aspect of the swept source ASOCT using Cassia. which uses the star 360 degree. So in the same section, we can see the clefts in multiple sections, and here you can see a blood clot in the inferior angle and in the 300 angle. So now that we have seen the different types of clefts, we can also assess the scarring post minimally invasive glaucoma surgery, and here you can see the scarred cleft. So in this particular case, the GAT leaflet has actually closed after surgery. This is 1 month post-op in which the leaflet has closed after the surgery. So now that we have seen how we can qualitatively assess, now we can also do a quantitative assessment using CASIA. So we can assess the angle parameters pre-operatively using this star 360 degree again, using the 2D assessment, 2D analysis. Sorry. So the angle parameters can be measured pre-operatively. And after post-phaco and GSL, you can clearly see the opening of the angle. So this is another index also, that is called the ITC index, the iridotrabecular contact index, which actually predicts the angle closure. So this ITC index can also be used before and after surgery to show that there is enough opening of the angle. So here you can see the pars areas post-surgery. Again, here you can clearly see post-op AIOS2025 showing the ITC index in the green. So this shows that the angle has completely opened up post-goniosynovial lysis. So another way of assessing using AIOS2025 is the measurement of the Schlemm's canal area. So sir had previously shown in the case of eye vent. So I'll just show how to measure this using the AIOS2025. So you have to select a session where the Schlemm's canal is clearly visible. And then using the same machine, you can mark the borders of the Schlemm's canal, and the machine will automatically calculate the area and the circumference of the Schlemm's canal. So this can be utilized for pre-op assessment as well as the post-op assessment, and see the changes in the Schlemm's canal area and the circumference, how beautifully it has increased after the minimally invasive glaucoma surgery. So this may be one way to assess the impact of MIGS pre and post surgery. So another thing that we can do is measuring the length of the cleft. So how is the cleft, whether the cleft is closed, whether the cleft is scarred, all these things can be well and clearly seen with the high definition swept source AIOS2025. So there is a meta-analysis which included multiple studies, so 8 out of 21 studies with Zen, trabectome, iStent inject, KDB. So majority of the studies used AIOS2025, and they have shown that AIOS2025 can be used to objectively determine changes in the anterior chamber angle anatomy. So this is one paper by Aparna Rao ma'am. She was actually showing previously how the scarring response varies with GAT and MIT. And one interesting point that I noted was the severe scarring in the form of a trench pattern, which seemed to predict the need for medications for IOP control. However, they independently did not influence the IOP final or the surgical outcome. So we don't know whether these structural changes are actually going to correlate with the intraocular pressure is something we don't know yet. Another thing that is coming up is the OCT angiography. So AIOS2025 angiography can be used to look at the images of the sclera and the conjunctiva at the nasal and the corneal limbus. So this particular study interestingly shows there is a reduction in the deep vessel density. So this is the preoperative image. If you see the post-op image, there is a reduction in the vessel density, and this was shown to be directly associated with the intraocular pressure reduction. So to summarize, with so many MIGS procedures in the block, we need to assess the MIGS objectively as well. And AIOS2025 using swept source can help in pre-op evaluation, intra-op assessment, as well as post-operative monitoring. However, the future direction should aim at standardizing the AIOS2025 protocols. Right now, we don't have any standardized protocols, so we need to standardize these protocols specifically for minimally invasive glaucoma surgery outcomes. I would like to thank my mentor and my academic team